Good morning, everyone, and welcome to our annual finance update for GP practices. It's lovely to see so many people have joined us again this year, and welcome to all those who are joining us for the first time. My name's Kay, and I'm Head of Healthcare here at Duncan and Topless. We have a dedicated specialist team to support our practices, ranging from services to act as virtual finance manager, bookkeeping services, accounts, taxation, pensions, to multi-million-pound property deals and allowances claims, as well as PCN and Federation business support. Today, I'm going to start by running through the 2023-24 contract changes, and then my colleague Damon will be covering our payroll update. I'd just like to say a quick congratulations to Annette Stewart and Damon Tunnicliffe, who many of you will know. They have both been promoted to Associate Directors from the beginning of this month, so congratulations to both of them. We have a lovely and very knowledgeable healthcare team with many years at Duncan and Topless between them, and so a thank you to them all. I feel very lucky to work with such a great team. Can I please just ask that if you do have any questions as we go through the session, could you note these in the chat section, please, and then we'll respond to them at the end. There is also a feedback form sent to you after the event with the opportunity to ask more questions, but don't forget to leave your email addresses, please, because otherwise the feedback forms do come back anonymously, so we won't know who to reply to. So this morning, as I mentioned, I'm actually going to cover the contract updates, but also a few other topics because the contract update won't take too long. And so we're going to look at those first before moving on to a little bit about maximising income, inflation and rising costs, the budget and how it may affect the partnerships or sole traders, and the usual hot topic reminders at the end. So I'm sure that you are all aware that talks between the government, the BMA and NHS England collapsed, and so the contract has not been agreed. It's being imposed again. There were talks and many of the requests were not acknowledged, such as using unused balances to support practices with covering the additional staff costs. But no, this money had to go back to the Treasury, so no help with inflationary costs. The letter that you'll have received talked about the commitment to publish a recovery plan for general practice access in early 2023. It should set out how practices and PCNs can be supported to improve access during 2023-24, building on the contract changes, but typically is still to be seen. The goal of the contract changes is to improve patient experience and satisfaction, and to support this, the contract changes attempt to free up workforce capacity through significant changes to the Impact and Investment Fund and through the QOF, the Quality Improvement modules. It's really important that practices are aware of the contract changes and the impact that these have on funding and workload. So what are the changes that practices will see in 2023-24? Well, 23-24 is obviously the final year of the 5-year framework agreement, which was set out in investment and evolution. And the table on this slide shows the investment in contract baseline and percentage increases, along with the movement in the Rs funding to 2022-23, and the figures that we were given last year in respect of 2023-24. But again, no final figures have been published at the moment. So moving on to the next slide, we can see here the global sum contract payment, and that has been uplifted from £99.70 per weighted patient to £102.28 per weighted patient. That's an uplift of just over 2.59%, and these were all calculated in 2019 and do not take into account the current levels of inflation or current cost pressures. The funding is deemed to provide a 2.1% pay uplift for all GPs, practice staff and practice expenses. GPC did seek additional funding, but it was refused. So obviously in real terms, as things stand, this is a pay cut for practices. The out of hours adjustment for GMS practices remains at 4.75%, with the equivalent adjustment for PMS practices being assumed to be an increase to £4.85 per patient. Again, we await publication of the final figures for PMS practices. The value of a QOF point increases to £213.43, and the CPI adjustment from 9,374, so that's the average list size, deemed list size, to 9,639. maximum points remaining at 635. But there are changes which we will cover shortly. Just to clarify though, as in other years, the increase in pounds is offset by the increase in the average list size. In respect of QOF, most indicators have been based on data from the end of the QOF year and can be worked on throughout the year with a tidy up at the year end. But an increasing number of indicators have a deadline that may fall before the year end, and so you do need to make sure that you are aware of the deadlines, because there's no way to retrospectively update and claim. So indicators with limited time are AST006, newly diagnosed asthma patients, where spirometry or another objective test between 3 months before and 6 months after the diagnosis confirmed the diagnosis. Other ones that are time limited are CAN004, the newly diagnosed cancer patients who had a cancer care review within a year of a new cancer diagnosis. CAN005, newly diagnosed cancer patients who received an offer of support in primary care within 3 months of a new cancer diagnosis. Provision of information about cancer support services is available in primary care. COPD008, that's COPD patients whose MRC is higher than 3 and received a referral to pulmonary rehab within the current fiscal year. DEP003, newly diagnosed patients with depression who received a depression interim review between 10 and 56 days following the diagnosis. DM015, newly diagnosed diabetic patients who received a referral to diabetes structured education programme within 9 months after diagnosis. And HF005, newly diagnosed patients with heart failure who had an echocardiogram or specialist assessment between 3 months before and 6 months to confirm the diagnosis. So you need to make sure that you set yourself up early in a QOF year with a robust system to ensure that you succeed and meet the targets to get the money that you're working so hard to achieve. Run searches regularly and ensure everyone is coding properly and exception report as necessary. Check your data frequently and make use of your IT. Make sure all of your team know what they should be doing. NHS England are still committed to an equitable and consistent approach to funding the core services expected of all GP practices, and so all PMS and APMS practices, unless there are local agreements setting out a different approach to secure equitable funding, are expected, but again no confirmation yet, to also get a £2.58 per weighted patient uplift. Throughout this next year, NHS England have said that they will be engaging with general practice, patients, integrated care systems, as well as government and stakeholders to build further on the fuller stocktake from May 2022, which sets out the next steps towards integrating primary care. So what was the fuller stocktake? That was the final report of the stocktake undertaken by Dr. Claire Fuller, who was at the time the Chief Exec Designate for Surrey Heartlands ICS and GP on integrated primary care. It looks at what is working well, why it is working well, and how implementation of integrated primary care can be accelerated, incorporating the 4 pillars of general practice, community pharmacy, dentistry and optometry. Also during 2023-24, GPC England and the Health and Care Select Committee will consult on with general practice and patient groups on the future of QOF. It has been announced that NHS England will review dispensing fee scales as part of the broader changes to the contract in 2024-25 too. The dispensing fee scales are reducing by 13.6% this month compared to the October 2022 fee scales. So dispensing practices in particular need to ensure that they are spreading the dispensing across the GPs and raising scripts appropriately to maximise their income. If you're unsure, then please do contact us. Going back to 2023-24, within Global Sum 2022-23, there was a continuation of funding, 20 million for 1 additional year to reflect workload for practices from the subject access requests. The original 5-year deal had assumed that this funding would cease beyond 21-22. The technology has still not caught up, and so it was asked that this funding be recurrent, but again, unfortunately, the government said no, and this has been withdrawn. For now, though, the 2023-24 contract changes fall into 4 main categories. And they are access, performance-based funding, workforce flexibilities, and immunisations and vaccinations. So if we first have a look at access, practices can't request that patients contact them at a later date. Instead, patients should be offered an assessment of need or signposted to an appropriate service at first contact. So you don't have to be seeing them yourself, you can refer to others, for example, community pharmacies, urgent care, get them to self-refer, for example, to physios. The 2-week rule is for those calling for the next available appointment, not for follow-ups or planned reviews, for example, for long-term conditions. Future online record access will be offered to all patients by the 31st of October 23, unless they have decided to opt out or exceptions apply. The BMA are in discussion regarding this. They're not opposed to it, but they do want to ensure that it is done in a fit and proper way. The cloud-based telephone national framework will be mandatory, and only cloud-based solutions will be supported by the end of 2025. Practices must procure their telephony solutions through the Better Purchasing Framework when their current contracts expire. There's been no guarantee that these costs will not be more expensive, and there will be no support if the costs are more. The enhanced access requirements will be reviewed in 2024 following discussions with PCNs and urgent and emergency care. Performance-based funding. So if we look first at the IIF funds, the Investment and Impact Fund, 5 indicators now, down from 36, worth 59 million. And these indicators will target flu vaccinations, that's 2 indicators, learning disability health checks, early cancer diagnosis, and 2-week access targets. The remainder of the IIF, worth 246 million, will target access and patient experience. This is what is called the Capacity and Access Fund, and it will be split into 2 parts. So 70% of the funding, 172.2 million, will be paid monthly as part of the Capacity and Access support payments to PCNs. PCNs will need to agree an access improvement plan with the commissioners in Q1 of 23-24, so in this quarter, and the remaining 30% of the total funding, 73.8 million, will be paid at the end of March 24, following an assessment of the improvements promised in the plan and what was delivered to patients. Guidance on this assessment will be provided to ICBs by NHS England. The Learning Disability Health Checks indicator will be amended by adding a requirement to record the ethnicity of people with learning disabilities. Moving on to QOF, 97 million in funding is to be released to practices by reducing from 74 to 55 indicators. All register indicators will become income protected based on 2022-23 output, and payments will be made monthly. Just to note here too that over the last few years we have seen income being protected, but it is still important to ensure you are coding everything correctly. Although there are protections, if you can demonstrate doing better, you can still gain more. Disease registers are an example, as you need to maintain these registers, otherwise it impacts on the pounds per point. So they are saying a reduction in bureaucracy, but it isn't really. Also, we have Leicestershire with the baskets of service with little or no information on how the calculations are made. And we have seen various income protections in other areas. So do ensure that you know what activity is in your practice, because this may still help you negotiate more money or argue any unfair disadvantages in the future. New QOF indicators include 2 cholesterol indicators worth 30 points, approximately 36 million. There's a new overarching mental health indicator, replacement of indicator AF007 concerning atrial fibrillation with AF008. Rheumatoid arthritis will be retired, and the value of DEM004 annual dementia review will be reduced. 2023-24 QI models emphasise the use of data, workforce and partnering with local services to improve workforce wellbeing and balance demand and capacity. There's going to be a consultation on the future form and suitability of QOF, and that will be undertaken in 2024-25. Moving on to R's workforce. So R's workforce flexibility, there are new roles. The advanced clinical practitioner nurses will be included in the R's as advanced practitioners. Apprentice physician associate, whatever. The cap on advanced practitioners will be raised to 3 per PCN under 10,000 patient population and raised to 6 for the larger PCNs over that amount. The cap on mental health practitioners will be removed. The contract will also clarify that they can support some first contact activity. Time spent away from practice in education and training will be reimbursable for first contact practitioners. Advanced practice pharmacists will be confirmed as able to supervise clinical pharmacists. Staff employed through the R's scheme will be considered part of the core general practice cost base beyond 2023-24. So they are encouraging general practice to offer permanent contracts where appropriate and continue to recruit into the R's roles, as they are saying that they will consider that as part of the core contract cost. Moving on to immunisations and vaccinations. Sorry. Changes to childhood vaccinations, the clawback vaccination immunisations repayment mechanism for practice performance below 80% coverage for the routine childhood programmes will be removed. QOF indicator thresholds are to be changed to 81 to 89% for the lower threshold and 96% for the upper. This will see fewer practices receiving no payments across the 3 indicators, an improvement that will see quite a lot of practices benefiting, but the changes don't go far enough, and some practices will still not be in as good a position in respect of childhood IMS as they had been previously. The new personalised care adjustment will also be introduced for patients registering late, either late in age or late in the financial year, to be vaccinated in line with the immunisation schedule. The routine vaccination schedule for HPV and shingles will be changed to follow the latest advice from the Joint Committee on Vaccinims. A couple of other comments here. There are no new requirements being added to the PCN service specifications, although some action will be suggested to PCNs as best practice to be supported via guidance. Also, the weight management DES, 97% of practices signed up to the weight management enhanced service in 21-22, and the service continued in 2022-23, and it will continue in 23-24, but does remain optional. The referral payment remains the same as it was in 2021-22 at £11.50 per referral, but there continues to be a requirement for the explicit agreement of the patient for the referral. So as with a number of payments, the money is not going up year on year, and so in real terms, this is a pay cut for practices. A huge ongoing issue is recruitment and retention of GPs. The impact of taxes imposed in respect of pensions has had a particularly detrimental effect on GPs wanting to do additional sessions, or even as many sessions as they had previously. Declaration of earnings also doesn't help this. Many of our GPs are telling us they don't want the earnings, they want some life back, some time with their families, and not to feel run down and exhausted. How on earth politicians talking about making all GPs salaried think they'll make anything any better? I really don't know. So what recruitment and retention arrangements are going to continue? Well, the new to partnership scheme ceased at the 31st of March 2023, but for any new partners who are eligible and joined a partnership before the 31st of March 2023, they do have until the 30th of June 23 to submit their application. So if you just give everybody a nudge if they're new partners and they haven't done it yet, because over the last couple of years we have seen new partners joining and sometimes taking an awful long time before they do put their application in. So just support them and make sure that they do that, get that application in before the 30th of June. And you do need to make sure that they are a profit sharing partner and they have signed a partnership agreement before the 30th of June 2023 too. So just a reminder here to everyone of the importance of partnership agreements. Remember, if there's no signed agreement in place and there's a dispute, you are governed by the Partnership Act 1890, which amongst other things states that all profits and losses and capital contributions are equal between partners. We do have a team of solicitors at Duncan and Topless Legal Services who would be happy to assist if you need an agreement writing up or looking at. A number of other recruitment and retention initiatives continue. So the Targeted Enhanced Recruitment Scheme, which offers a one-off payment of $20,000 to attract trainee GPs to underdoctored areas. And Boston, Peterborough and Lincoln are on the list again for 23-24, and North Lincolnshire and Hull. GP International Induction Programme, Return to Practice Programme and the GP Retention Scheme that GPs and practices are making use of continue. The relaxation of the 4-session cap in respect to the GP retention scheme is being made permanent. And there is also the GP Practice Fellowship Scheme. So make sure that any of your new GPs and yourselves are tapping into these funds as applicable. So as I mentioned, I'm also going to just move on to a few other little tips and hints and reminders. So firstly, make sure you are maximising your income, particularly in respect of work that you're already doing. A reminder to ensure that everyone who should be coding and recording at your practice is aware of the coding structure and what needs recording, together with deadlines, as we have mentioned, and the correct and updated codes for 2023-24. Ensure any claims that require submission have been submitted as they should be, and follow through that the money is then received. We often see missing income that practices have actually claimed correctly, but it hasn't come through, as well as practices missing claims. Hopefully everyone has good financial control set up, and there are some great reporting features within software such as Xero these days to help you check for any gaps in income. One thing a couple of practices have missed this year are flu claims. So this amounts to quite a lot of money for practices, so do make sure that you are claiming the item of service payment as well as the drugs refunds. Flu is the most valuable drug any practice will deal with all year. Zoladex is obviously also another high value item. And follow through the checks that the money does come in, because there are now strict deadlines and so often things can't be claimed retrospectively, or there's a very short window in which to claim. So it's really important that you are monitoring through the year that the money has come in, even with good reasons, such as people who do or know how to claim are off sick or have left unexpectedly. So another tip is to make sure that you have backup and you are training deputies up. Are you making the most of your R's staff? We have seen examples of well-organised practices missing out and less organised practices benefiting within PCN, sorry, not PCSE. Don't get penalised for being good. Push for your fair share where possible. Again, back to PCNs, look at what you are doing. Are you getting paid for what you're doing? And is the money coming through in a timely manner? Make sure someone at the practice is going to every meeting possible and are aware of what can be claimed. Are you doing any work that you're not getting paid for? If so, do you need to be doing that work? Or could the team be doing something else that you could be getting paid for? Be aware of the dispensing fee thresholds to maximise income. The rates in pounds, as I've mentioned, is going down again. So the only way to maximise this is to be aware of the tiers, the thresholds, and maximise the scripts written in an effective way. Because volume per GP increases, and then the rates go down. So ensure that you are spreading them across the GPs. Also, of course, be aware of the refunds available for the types of drug that are being prescribed, and prescribe in the most cost-effective manner possible. Watch things like dressings and sutures. Some are claimable and some not, so make sure that you are using the ones you can claim where possible. With rising inflation, costs, utilities, it's essential to be aware of the impact these will have on your finances. If you need support with projections to plan, then please do speak to us. The two main costs for GP surgeries are staffing costs, and for dispensing surgeries, the drugs. This month sees the rise in national living wage, and Damon will be touching on this in his session. Careful consideration needs to be given to pay rises across the board. Practices need to be paying staff a sufficient rate to retain good team members and not risk losing them, and having to put resource into training new recruits. And so other areas to review are contracts, ensuring you cross-skill team members so that overtime can be minimised, and of course looking at the staffing levels and structures together with the right person for the right job for each task. Practices should review when contracts are coming to an end and consider using cost-saving experts. So this is in relation to utility bills, for example, to support you in finding the best deal that is possible for your practice. Flu purchases, another key area. So we have seen a couple of issues around flus, one being don't leave the purchasing too late and end up paying a fortune for them when you don't need to, and the other being to ensure that you are claiming for the correct flus given, as some attract a higher reimbursement than others on your PPA statements. Watch the level of purchasing and make sure you are letting patients know how important it is to support their local surgery by attending the surgery for their flu jab rather than their local pharmacy. So just advertise to your patients. Watch out for irregularities, such as people offering good deals on certain goods that might be false economy as well. So moving on now to the impact of the budget. So just a few notes here, because I know there are some GPs listening and some practice partners as well that might be impacted by some of these issues. So the added rate threshold has been lowered from 150,000 to 125,140. So this is where it jumps from 40% tax to 45% tax. Any practice partners who are listening will have heard us talking about the 60% zone for tax, which is where they have just tipped over the 100,000 taxable profits. And so for every £2 earned over 100,000, they lose £1 of their personal allowance. The drop in the added rate threshold now coincides with the point at which the personal allowance has fully disappeared. So additional tax payable for GPs with taxable earnings between 125,140 and 150,000. You're paying that extra 5%. The lifetime allowance charge has been removed from this month. Annual allowance has increased from 40,000 to 60,000. And the tapering of annual allowance does continue. The adjusted level of income required for the tapered allowance to apply to an individual has increased from 240,000 to 260,000, and the minimum amount that they can be tapered to increases from £4,000 to £10,000. They have removed the impact of inflation on the annual allowance calculation. So the Department of Health and Social Care will change the date on which NHS pension scheme benefits are increased with inflation from the 2022-23 year. And that will align the rates of inflation used in the annual allowance calculations with the revaluation of scheme benefits, and ensure that the annual allowance calculations only measure growth that occurs above inflation. This will reduce the impact of the annual allowance for NHS pension scheme members with the aim of retaining experienced clinical team who may otherwise opt out, reduce commitments or leave the NHS due to pension taxation. This means that more GPs will drop out of annual allowance tax payments, although higher earners will still have charges, but with improved thresholds. And finally, I'm just going to move on to a few tips and hints. Because we're starting with PCSE, I know some of the Leicestershire practices have seen this before, but this slide just really shows what's required in order to deal with PCSE and the problems caused by their incompetence. So we all know what we're doing afterwards. So, common problems that we've seen. PCSE rejecting certificates stating contributions are incorrect when it's their figures that are incorrect, as they've omitted their adjustments where estimates forms have been processed perhaps a few months into the new year. Rejecting certificates for no apparent reason, and when we question it, they just ask us to refile. Missing solo forms is a favourite. Sometimes they've had them, sometimes perhaps the GP's forgotten about doing the solo work, and sometimes the people that the GPs are working with haven't prepared them or done anything with them or the contributions. PCSE stating that they don't have older year certificates despite having had them probably for a number of times. Another common problem is PCSE deducting contributions for leavers and not deducting contributions for new starters. Not ceasing or starting deductions when GPs or partners are opting in and out. So a couple of tips here. Where you have a joiner, the new GP has to log into PCSE online and update their performer list details. Once they've submitted the change, it's sent to whoever holds the PCSE Online PL Practice Manager role to approve. They need to approve, and then the joiners process can be completed by whoever at the practice has been given the GPP joiners and leavers role. Once this has been done, the joiners should appear on your estimates form and you can enter their pensionable pay. For leavers, this process can actually be completed as soon as you know that the GP is going to be leaving the practice. This ensures that the pension contributions are stopped from the date of the GP leaving, regardless of when they update their performers list. So you need to log into PCSE Online, into GP Pensions and Payments, select Pensions and click on the practice leaver. You can then select the leaver and the intended leaving date. For GP partners and partners of the practice, they can opt out using PCSE Online. And the new opt-in instructions are that the practice needs to complete a joiner form for that GP or partner. So logging into GP Payment and Pensions, selecting Pensions, and then practice joiner. So although they're a partner, you as a practice need to be doing that for them. We do recommend with any contact us inquiries with PCSE or rejections that you keep a log of what you are doing and any case numbers. If there is likely to be a compensation claim, you need a timeline of events. Also a reminder here to carefully monitor the deductions that are being made for salaried GPs. Are they correct? And following up where deductions are not being made for existing GPs or deductions are being made for GPs who have left. A quick mention here also, check that contributions PCSE are taking do agree to your estimates forms and check that the balancing payments or refunds being taken for partners do agree to the certificates. Particularly watch salaried GP contributions and end of year adjustments. We see numerous issues, and one big one is that the salaried GPs do not always know what their pensionable pay is and often use either taxable or gross pay. So we do recommend you give all of your salaried GPs their pensionable pay and employee contribution figures each year so that it doesn't affect your finances. Don't automatically assume that the end of year adjustment by PCSE is correct and pay or recoup anything from the GP. The adjustments could be a mixture of what is owed to or from the practice to PCSE, as well as to or from the practice to the salaried GP. Or let's face it, it could just be wrong. For any of our clients, as always, please do contact us if there are any issues. Finally, estimate of superannuable profit forms do need updating throughout the year for any changes, so either ensure you update or contact us or your accountant where these need completing during the year. Just a few other notes. PCN profits for inclusion in practice accounts. This is just a reminder that we will need to see these when preparing the accounts. We have had instances of being advised that there are no profits to declare when in fact a year or two later we discover that there should have been. We understand that it's frustrating for GPs to pay tax on profits. They don't see due to PCNs wanting to reinvest in future years, but unfortunately it has to be done to comply with HMRC. We do in our accounts monitor who pays tax when to ensure that anyone leaving does not leave in a position where they are out of pocket in any way in respect of tax payments and PCN profits. There's also a lot of work being done with PCNs to look at how to shelter profits. We do appreciate that in some cases it has been difficult for practices to get answers or figures from PCNs, and their answers have been based on what they've been told. I think over the last 12 months things have definitely improved in most cases. There are, of course, new pension tiers for employees coming in again, and I'm sure Damon will touch on this in a few minutes. But just to be aware when you're looking at giving staff pay rises of the implication of where they are in relation to the next threshold for pension deductions. GP earnings declarations. Practices should have declared their GP earnings figure on their website by now for 2021-22. This is not the same as the declaration of earnings in excess of 156,000. This is the one that needs declaring on your website. The GP earnings figure is the totally meaningless and ridiculously calculated figure that needs putting on the website. The GP earnings declaration for any GPs earning over 156,000, this is where you have to declare, and the BMA have confirmed that the new regulation applies to practices that have had their contracts varied to include the new rules, with a 14-day contract variation notice. The legal advice that the BMA received is that no practice has a contractual duty to comply with the new rules of declaring that 156,000 if it's breached until it's served with a 14-day contract variation notice and the period of notice has expired. Do note that if any GPs are over the limit and don't declare, and should have done, the practice is in breach of contract. So just something to watch out for. Once again, something to encourage GPs to keep their hours down where there is a shortage due to unfairly targeting them to declare and the repercussions declarations may cause. The figure that is used for this calculation of the 156 is the pensionable profit. Finally, a reminder for any non-March year-end practices that the basis period for tax is going to be changed. Non-March year-end should be looking at implications of changing their year-end to March from March 2024. In order for the partners to access the easement rules and spreading the release of overlap taxation over 5 years, they would need to be changing it to March 2024 if they were going to change the year-end. If anybody is leaving or retiring ahead of those 5 years, then it would need paying all in full at the point of retirement or leaving. It may be beneficial for additional tax to be released in earlier years if profits are changing and if you're likely to fall into higher rates of tax or lose personal allowance in a future year. So this is an individual tax planning point for each partner within a non-March year-end practice that should be looked at individually. And that brings me to the end of my presentation. So thank you very much to all of you. I will check for questions in a minute whilst Damon is doing his session. So without further ado, thank you very much, Damon. I shall pass over to you.
Thanks, Kay. Good morning, everybody. And it's great to be here today to present the NHS payroll and pensions update for the 23-24 tax year. It makes a nice and unusual situation that there aren't too many changes from HMRC for the forthcoming year. I appreciate there are a lot of numbers I'm going to talk about, but hopefully it gives a further understanding of what makes up a payslip. In the autumn statement, Jeremy Hunt said income tax thresholds will remain at the same limits until 27-28 as the government looks to raise extra income to plug a hole in the public finances of about £55 billion. So it means that the personal allowance remains at £12,570 for the year, which is £1,048 per month before employees start paying tax. The 20% band is up to annual earnings of £37,700, with the 40% band between £37,701 to £125,139. What is interesting here is that with the bandings remaining the same until 27-28, we will all be paying more tax and national insurance in the years to come as with salaries expected to rise. However, if we have a general election next year, expect that to be changed. The national insurance thresholds are once again aligned with the tax thresholds, meaning that the primary threshold is £12,570 before employees start paying national insurance. NI isn't like pay as you earn though, where it is accumulated over the tax year, but is based on point of payment. So for a monthly payroll, employees will be paying 12% on any earnings over £1,048 per month. I've mentioned the 12% on purpose there, as for part of the 22-23 tax year, it did increase to 13.25% for the additional 1.25% for the health and social care levy, which was scrapped in November. The lower earnings limit remains the same at £6,396, which is £533 per month, which is the minimum amount that people need to be earned to be eligible for their NI credit for their state pension and to be eligible for statutory payments. The secondary threshold will also remain at £9,100. So anybody earning over £758.33 per month, then the practice will be paying 13.8% of employer national insurance. For those employers that have a nest pension scheme, this is also not changing, as the workplace pension bandings for those employers that assess their pension using the qualifying earnings. The lower earning level of earnings remains at £520 per month, with the higher level capping at £4,189 per month. However, NHS pensions have now confirmed that the proposed flexible retirement options have been accepted by the DHSC. With this confirmation, from the 1st of April 2023, any past or present 1995 retirees can be enrolled into the 2015 scheme. As per the new section of the NHS pension website, employers are not required to enrol these staff from the 1st of April, but they are required to inform the staff members affected that this option is now available. Therefore, notify the staff affected of this change by directing them to the NHS Pensions website about the proposed changes. If 1995 retirees pre-April 2023 wish to go back into the NHS pension scheme from the 1st of April, then they'll have to complete the following process. Those who haven't already opted out of Nest will have to opt out of Nest, and it is their responsibility to do that. From the 1st of April 2023, all members claiming the 1995 benefits and returning to work will automatically be enrolled into the 2015 scheme on their return date. The Department of Health and Social Care has also permanently removed the 16-hour requirement from the 1st of April, as long as a member has had a break of 24 hours from their previous job. This can be a weekend, as it is based on calendar days, and then they'll be able to move to a new employment contract and start building 2015 benefits immediately. The other big update was that tiered pension bands. The process to remove the tiered pension bands is linked to the Agenda for Change annual pay settlement, and tiers are amended as part of that process. The tiers from the 1st of October 2022 were a temporary arrangement, and the next phase date is a ministerial decision, but well could be the 1st of October 2023 or the 1st of April 2024. Aggregation of multiple assignments to determine the tier is still on the table, but due to the complexity for payroll providers and administrators, this is not expected to be implemented soon. The employer NHS pension rate is to be reviewed on the 1st of April 2024, but no further update is available at this time. One good thing is that you don't have to record each mid-year change on pensions online when completing the SD55s. From an admin point of view, I mean, that's great, it's less time, but from a reconciliation point of view, I do wonder how they would tie everything up. So I would be very cautious when entering figures in this year. It's the employee's responsibility to check their payslip each month, ensure their pension is correct, as ultimately it's their pension that's going to get paid to them when they retire. We do our absolute utmost to ensure that all compliance is met when processing the payroll if you outsource to us, and I know a lot of you are conscientious and raise any queries when checking with us. With this said, we are looking to run a webinar for employees and understanding the NHS pension. We have trialled this with a practice and the feedback was really positive, with them gaining knowledge of the subject, so we're now looking to do this on a larger scale in the summer months. Firstly though, we also have a webinar coming up on Wednesday the 10th of May. And I'm not sure if the invites have gone out yet because it was only agreed at the start of this week, for employers to assist with the year end and preparing the SD55s. So if you are unsure about creating and processing them this year, I would definitely advise to wait until that webinar to watch that before completing, as the deadline for completing the SD55s isn't until the 31st of May. We've created a year-end pack as usual to make the submission as easy as possible. And these we're looking to be issued to practices by the first week of May, just due to the April processing year-end and New Year starting. Just a reminder for your employees that when they are receiving their P60s, that the taxable figure is their salary minus the pension. As we do get a lot of inquiries where they believe the figure is incorrect, but they are looking at it on the wrong basis. Back to some payroll changes and student loan. And there are some changes to it that affects people on plan type 1 and plan type 4. Those thresholds for plan type 1 has slightly increased to £22,015 from £20,000 to £195. And plan type 4 has increased to £27,660 from £25,375, both payable deducted at 9%. There is no change to plan type 2 or the postgraduate loan. The plan type 2 and postgraduate loan are also to be frozen until 2025. There is a future plan type 5 that is coming, and that is currently just for practices in England, and that is based from the academic year from the 1st of August 2023. So the payroll deduction will likely start from April 2026 with a £25,000 threshold, which will be frozen until 2027. With all these changes now to student loans, it will be interesting to see whether HMRC update the P45. As at the moment, it just says student loan, yes or no. So if there is a yes, please ask your employees which plan they are, and please make sure that you're using the correct updated new starter form. And if anybody wants an updated new starter form, please let me know, and myself or one of the team will get that across to you. Statutory payments have also slightly increased, so they have risen from £99.35 to £109.40 per week, and statutory parental payments have also increased from £156.66 to £172.48. So that's an increase from £22.38 per day to £24.64 for those on parental statutory payments. The recovery remains the same. That threshold hasn't changed from £45,000 on the small employers relief. If your NI bill is over that, then you can only reclaim at 92%, whereas if yours is less, then you are able to claim the 100 and then the extra 3% compensation. But we will do all, if we process payroll, we will do all that assessment for you. The government, I'm sure a lot of you have been looking at payroll this week. That the national minimum wage and living wage rates are now in force from April 2023, with the national living wage rising to £10.42 at an increase of 9.7%. 21 to 22-year-olds are now at £10.18 with a big rise of 10.9% there. 18 to 20-year-olds are £7.49. 16 to 17-year-olds and apprentices are £5.28. So a big jump in the minimum wage to look at. And then just a couple of final tips, really, that can aid some efficiencies. Pay-as-you-earn direct debit is now live. That has to be set up by you at the practice, and that's set up by your business tax account or your HMRC government gateway, as probably what it used to be called. And you've got to set up that at least 8 working days before the payment due date. So to be paying, if you did want to set up, for example, for the 22nd of April, that would have needed to be set up by the 12th of April. So if you're looking to get into one less task of setting up HMRC payments, then that's something that you can look at for the 22nd of May or onwards. So once it's set up, you're sent a message by the BTA to confirm that it's been taken, and this message will be sent on the 20th of the next working day. Collection of funds, actually though, is the 3rd working day after the message is sent, which on a normal working week would be taken on the 23rd. However, we all know that the payment should be by the 22nd. It does result in a late payment charge, but as soon as the payment is received, then the charge is removed. And there was some initial teething problems, but that is now resolved, and we've got clients using that. And then just a little bit again for your employees. Again, what we get queries on is about their tax codes. We strongly recommend that they use their personal tax account app. We do not have a clue what makes up the employees' tax codes. That is personal to them. HMRC will only talk to the employees. So rather than sitting on the phone for a long time, then it's definitely advisable that they set that up. And they can also update any of their details, and such as change of address or name, for example. So that is all of my payroll and pensions update, and I will hand over back to Kay.
Thank you very much, Damon. Right, well, I've checked in the Q&A and I can't see any questions. I have popped my email address in the Q&A box so that if anybody does want to contact me separately, you can do. And Will's just popped a message in there to say that if you do want to re-watch the Will's saying there are a few questions. I hadn't spotted those. I'll have a look in a second. Yeah, so he said that alternatively, the recording will be uploaded to YouTube, but you can access it by clicking the same link that you've used. Right, I see. There's a new question here. Where did the 156,000 earnings have to be declared? There is a website, and what I'll probably do is I'll make a note of these afterwards, and what we can do is send out a link. There's a link that you have to sign into to declare them. So I'll add that to some feedback that we can send out to all the email addresses that we've got as being logged. If you want to just drop me an email, because it comes up as anonymous, just to make sure that I have got your email address on the list so that we can send that to you so that you can see what to do. It's got full instructions of what you need to do. Right, yeah, so when you say ours role should be core contract, what do you mean? I think you're saying, what do you mean? So I think what they're saying there is that they're looking at beyond 2023-24, they're looking to consider that those ours roles are part of core contract funding, so that the funding will be there, whatever form the future takes, the funding will be there to support that. Let's be honest with each other. We can see what the what happens with funding, you know, the general fact that you're expected to do things and money is thrown at practices, and then you're expected eventually to do it without that funding. So yeah, it's whether that comes to fruition, isn't it, realistically? When entering joiners' salary on PCSE from members starting partway through the year, should you enter the annual salary or the actual earnings? Okay, so not the prorated amount, it needs to be the full annualised amount on there. So if they start partway, if they start 6 months in the year, you don't put half the salary on, you still put the annualised salary on. Is the 2.1% uplift a definite? I keep hearing the contract hasn't yet been finalised. It is in the statement, well, the statement of financial entitlement, which is where I got my figure from, has now come out. So it is the £102.28, which is deemed to cover the 2.1% uplift. But as I probably mentioned as we went along, it's deemed to give you the 2.1% uplift, but in real terms, it's not going to give the 2.1% uplift because inflationary costs, the utility costs and national living wage impacts, that 2.1% realistically isn't going to be seen on the bottom line for the GPs based on the sort of core contract work that's being done and the staffing to support that. So I think that's covered all of the. Yeah, I've covered everything that's there at the minute. Has anybody got any more questions they want to type up before we disappear for myself or for Damon? So we can follow up with a link with the details of where to declare those the GP earnings over 156 and the instructions of what you need to do. Nothing popped up at the minute, but as I say, if you click on the published items, my email address is there if anybody does want to email me directly or email into our marketing team by the email that came out. Okay, well, thank you very much for joining us. It's great. I can see we've got lots of attendees, which is brilliant. Thank you, Damon, for coming on and doing your payroll update for us as well. And thank you, Will, for your support with putting it all together. So thank you very much, everybody. Have a lovely day and hope to see you soon. Bye.